Good afternoon, everybody, and good morning to our colleagues in the US. Thank you for joining in our today's PEM lecture series number 5. And today we have another interesting topic which says tiny heads, big decisions, pediatric traumatic brain injury, recognition and stabilization in the ED. And we're going to have two presenters that are going to take us through this interesting and very important topic at the emergence, where we have Dr. Chidi Ugu, who is an assistant professor of pediatrics and an attending EM physician at Dell Children's Medical Center, Texas in the US. And we have Dr. Biita and who is a pediatric emergency medicine fellow at MUHAS. So just a few things to remind ourselves before we kick off the talk. This is a CPD accredited activity where each and every one of you that joins in today is going to have 3 CPDs. And just to inform you, the MCT portal that we claim CPD is now functioning, and I'm working to make sure that we all get our CPDs for all the 5 sessions that we attended. These are recorded lecture series, and we have a YouTube channel where we have posted all the previous recorded lecture series. So if you missed any, you can always go to our YouTube channel, which I'll share the link on the chat, and you can always go back and keep on learning. So I'd like to welcome you once again. Thank you for joining in. So I'd like to welcome Dr. Biita and Dr. Chidi to go ahead.
Yes, good afternoon. First of all, thank you, Emory and MUHAS, for giving me the opportunity to present in this forum. The topic is about recognition and stabilization of pediatric patients with traumatic brain injury in the emergency department. My name is Dr. Biita MUHAS from Pediatric Emergency Fellowship at MUHAS. Sorry, the slides are not moving. Sorry, the slides are not moving. Yes. So this presentation will have two parts. Would have two parts. The first part will be presented by me. It is about traumatic brain injury overview, specifically covering the introduction, causes of pediatric traumatic brain injury, signs and the symptoms of pediatric traumatic brain injury, assessment of a child with traumatic brain injury, the severity of traumatic brain injury, and the differentials of traumatic brain injury. And the last will be about the investigation in a pediatric patient presenting with traumatic brain injury. Sorry. The slides are not moving. I don't know why.
Okay, so maybe we could just stop sharing and then reshare again.
Okay. Okay, so what is pediatric traumatic brain injury? So this is a disruption of the normal brain function due to mechanical impact on the brain. This mechanical impact can be due to blunt object or penetrating object. Traumatic brain injury is a spectrum ranging from mild form to severe form of brain injury, based on Glasgow-Coma scale of the patient. It can be a primary brain injury or secondary brain injury. In the subsequent slide, we'll discuss in detail what is a primary brain injury and what is secondary brain injury. So pediatric patients or children are more vulnerable to traumatic brain injury if we compare with the adults. So this vulnerability, it is because of the anatomical differences, physiological differences, and the developmental differences. We will see in details what are these differences. Starting with anatomical differences, which makes a child more vulnerable to traumatic brain injury. One is that the child or children have larger head to body ratio. That means the head of the child is more protruding forward, protruding back, protruding on the right, on the left. That means it is very easy to receive the first impact from the mechanical impact. So as a result, the child will have more head injury compared to adults. Again, the child, they have short stature. If you compare with adults, the child will have head injury, where the adult will sustain injury on the lower extremities if both are pedestrian. Because the child is shorter, the adult are longer, so the first impact will go to the head, where to adult, the first impact will go to the lower limbs. Again, the neck of the child is softer compared to the head, to the neck of the adult. This is because in adults, the stability of the strength of the neck is depending more on the bones, the vertebral bodies, and the strong muscles and the strong ligament. When in the child, the bones or the vertebra are underdeveloped. So as a result, the neck is more soft. It is very easy during the impact to move back, to move forward, to move right or right. As a result, the child will suffer from acceleration and acceleration consequences compared to adult, where the neck is so strong that when it is hit, it is not easy to move. Again, the brain of the child is more softy, is more watery if you compare with the adult. Being more watery, it means even a minor impact on the brain will cause, on the head, will cause a significant injury in the brain tissue. Again, the skull is more thin and elastic. As a result, because of the very thin, the penetration from the penetrating object, it is more easier in the skull of a child compared to the adult. Again, because the bones are so elastic, it is very easy for the child to have severe brain contusion compared to the adult, where the skull is so strong, there is no overlapping with the sutures. Again, the child has open fontanelle, has open sutures, which again puts them at risk of having severe brain injury from contusion if you compare with the adult. The physiological differences or the physiological vulnerability of the child, one is due to hypothermia. The chance of developing hypothermia is higher in a child compared to adult because of larger surface area. Remember, hypothermia is one of the lethal triad in trauma. Again, another physiological difference is that the blood volume of a child is small compared to adult. So even a small bleeding from the scalp injury will push a child to hemorrhagic shock if you compare with the adult. Again, the brain of the child is more vulnerable to swelling compared to adult. As a result, even a minor injury on the brain would result into significant swelling of the brain. Another physiological difference is that the ICP and the blood pressure of the child is lower compared to the adult. So for the child to develop signs of ICP, we take more time or longer time compared to the adult. As a result, the child may suffer several consequences of the brain injury before you recognize that the child has raised ICP. Another pathological difference is that a child, when it gets head injury, will end up with diffuse injuries, where an adult will get focal injuries. Again, the child, his seizure rates is high. The chance of developing a seizure after head injury or brain injury is higher compared to the adults. So the child may likely to present with a seizure post brain injury rather than compared to the adults. Another pathological difference is that the child has unique entities. For example, growing skull fracture, scaola, and the non-accidental injuries. This is because the brain of the child is progressively growing. So if the child has a skull fracture, because the brain is growing, the fracture will continue. That's what we call growing skull fracture, which is different from the adult one. Also, there is a clinical challenges in dealing with a child with traumatic brain injury. For example, the child who cannot express themselves, especially those below the age of 2. They cannot communicate if they have headache, if they have dizziness, or if they have amnesia, which makes it challenges in recognizing early traumatic brain injury in children. Another challenge is that in a pediatric patient, we cannot use a Glasgow Coma scale we use in adult. We need a more modified Glasgow Coma scale for the child. So if you use the adult one, you may end up having a different diagnosis. Again, the parents, when it presents to the emergency department, it's saying, my child is not acting well. That may mean a serious injury to the brain of the child, and you need to be more cautious on that. So, what are the causes of pediatric traumatic brain injury? According to the studies done in the United States, it was found that the leading cause of injury in the United States in a brain injury is fall, which is accounting for 55%, followed by non-intentional injuries, which are counting 24, and then followed by motor vehicle accidents. But in our settings, including the study which was done in Kilimanjaro, KCMC, which was another study done in Bugando, they pointed out that the leading cause of traumatic brain injury in children are motor traffic accident and the fall. Those are the two most common causes. But also, we have other studies done in other parts of Africa. For example, in Cameroon, in the study which was done about traumatic brain injury patterns, they found that in the leading mode of injuries, number one was road traffic accident, which accounted for 46%, then followed by fall, followed by assault. So these are one which are common even in Tanzania: road traffic accident, fall, and assault, and the rest. So traumatic brain injury in a child can be classified as primary or secondary injuries. Primary injuries are those injuries which occur during the impact, during the physical impact on the head. So when a child is hit on the head, during the process of hitting that child, the child will develop injuries immediately. For example, bleeding within the intracerebral bleeding, cerebral epidural hematoma, subdural hematoma. Those are the primary injuries that are occurring during the impact. But however, the child can develop secondary injuries as a complications of primary injuries. For example, if the child developed intracerebral hemorrhage, or epidural or subdural, then the mass effect from that hematoma will cause the brain to herniate. So herniation is what we call secondary injuries. But also child can have associated injuries. For example, chest injury, abdominal injury, long bone fractures. All these can cause a child to go into shock or to go to hypoxia. So hypoxia and hypotension can cause brain injury. So those injuries are resulting from associated injuries, which are resulting from hypoxia, from hypoglycemia, from shock. Those we call it secondary injuries. And actually, from studies, it seems that in a pediatric patient, the most cause of poor outcome are secondary injuries rather than primary injuries. Again, secondary injuries are treatable. Emergency medicine provider can do something or can intervene to prevent secondary injuries. So what are the signs and the symptoms of traumatic brain injury? So the signs and the symptoms depends on the age of the child, depends on the the age and the severity of the injuries. For example, the children of young age, they may present with inconsolable crying, persistent crying, fusiness, or they may present with lethargy, unusual dullness, or trouble to sleep, or they present with sudden loss of acquired skills. For example, if a child was able to walk before the injury, after brain injury, the child is not walking, or child was able to speak, and after head injury, cannot speak. So you need to suspect that the child may have head injury if there is sudden loss of acquired skills. Again, other than the physical differences, for example, they may present with the headache. They may complain of dizziness, but these are for those who are able to express their concern, those who can able to talk. But for those who are unable, especially those under 2 years, they cannot tell if they have a headache, if they have dizziness. Again, those who can talk, they can express if there's amnesia or not. There is another study which was done in Cameroon looking what are the clinical presentation of these children presenting traumatic brain injury. It was found that loss of consciousness with the reading, followed by scalp wound, followed by periorbital ecchymosis, followed by vomiting, headache, and the seizures. So if you see this in children suspecting traumatic brain injury, if the child is presenting trauma, if he has vomiting after trauma, think about brain injury. Child has scalp wound, think about the brain injury. If the child is altered level of consciousness, don't forget to consider traumatic brain injury. So the assessment or the approach in handling this child, you need to do a systemic thorough examination. One is to start with the primary assessment, then with secondary assessment. Primary assessment, we need to focus on A, B, C, and D. For example, airway assessment should go hand in hand with cervical spine immobilization, because we know if the child has C-spine injury, during the assessment, you can cause more injury, then the child can progress to respiratory failure or can go even to arrest. So you need to establish the C-spine during the primary assessment. In the primary assessment, you need to focus on identifying any cause of airway compromise. For example, presence of a foreign body, presence of bleeding in the oral cavity, loose teeth, facial laceration, unstable facial bone fractures. These are the signs that which show that the child might have compromised the airway. And you need to maintain the patent airway. Otherwise, the child will go to hypoxia and then go to secondary injuries. Maneuvers which you can use to open the airway is similar to non-trauma child, like suctioning, putting an oral airway adjunct, using simple maneuver, and even intubation when needed. When you're assessing the breathing, make sure you assess if the child has sign of respiratory compromise, because the head injury itself can compromise the airway, but also child may present with chest injuries, and the chest injuries will cause secondary injury. So make sure you assess the breathing, you identify the sign of respiratory compromise. If the child has hypoxia, correct it. If the child has no air entry on one side or intention pneumothorax, make sure you fix it. On the circulatory part, make sure you assess the sign of poor perfusion, like the cold extremities, tachycardia, active hemorrhage. Make sure you intervene. If the child is in shock, make sure you put IV access, you draw urgent blood group and glucose match, you give IV fluid accordingly. Remember, don't overload the child. If the child on circulation assessment, you find the child has Cushing triad, like bradycardia, altered breathing, hypertension, think about brain herniation. On a disability, again, you need to assess the level of consciousness, you need to assess the pupil size, you need to check the blood sugar, you need to check if the child is active seizure. If the child is actively seizing, it is also causing a secondary injuries. If the child has hypoglycemia, it is causing a secondary injury. So make sure you fix if you have an abnormality in disability. On exposure, make sure you check the presence of associated injuries. Don't focus on the head. Check if the child has extremist fracture, if the child has abdominal sign of abdominal injury, if there's a sign of chest injury. Make sure you check, you recognize, you treat. Otherwise, you cause secondary injuries to the child. Again, after primary assessment, you need to go to secondary assessment. Again, you need to be focused. You make sure that you don't miss any findings in secondary assessment. The easy way is to start from the head, going downward, rather than starting with the most affected system. For example, when assessing the head and the neck, you can check if there is a presence of swelling, if there is any scalp laceration, if there is any bleeding, if the child is bleeding from the nose, if the child is bleeding from the ear, or the child is bulging of fontanelle. This indicates the presence of brain injury. On a respiratory system, check if the child is breathing. If the child is not breathing or is in apneic, think about spinal cord injury, which can cause respiratory muscle paralysis. Check if the child has a sign of Kenny-Stoker respiration. If you see it, think about cerebral hemisphere injury. If the child is hyperventilating, think about brainstem injury. So if the child is on the cardiovascular system, check the blood pressure, check the heart rate, check the jugular venous pressure and the heart sound. Hypotension, bradycardia, muffled heart sound, these can indicate serious injuries, not only because of the brain injury, but also because of the injury to the heart. As a result, the child will suffer from secondary injuries because of hypotension, because of hemorrhage. So make sure you recognize the life-threatening signs from the cardiovascular and you intervene accordingly. Again, you need to assess the CNS system. For example, presence of unilateral dilated pupil, think about presence of herniation, especially on the side where the pupil is dilated. If the pupil are pinpoint, think about pontine hemorrhage. If the child has signs of Horner's syndrome, think about injury to the hypothalamus or brain herniation. If there's nystagmus, think about cerebellar injury. If there is symmetrical or hyperactive deep tendon reflexes, think about head or spinal cord injury. Asymmetrical reflexes, it means there is a unilateral lesion on this side of the findings. Babinski reflex, for example, it is positive. It indicates the pyramidal tract involvement. Again, in assessing the GCS of the child, it is different from that of the adult, especially for those who are below 2 years. So don't use the adult GCS. Make sure you have a special chart for pediatric patient. It is modified. For the eye opening, it is almost the same. For the motor, there is slight difference, but for the verbal response, it is more different, especially for those below 2 years. The aim is not to memorize these findings. Make sure you have a special chart to score the child. That is the key point from here. There is no need for memorizing what is 6, what is 4. If you have a chart, you will score the child accordingly. So about the severity of brain injury, as I said at the beginning, that head injury is a spectrum from mild to moderate. So there are 3 ways you can classify the severity of head injury. One, you can base on the level of consciousness, Glasgow Coma scale, or the duration of loss of consciousness, or post-traumatic amnesia. If you base on the GCS, we have mild TBI will be a GCS of from 13 to 15, the moderate will be 9 to 12, and the severe form would be 3 to 8. If you are using the loss of consciousness duration, if the child is loss of consciousness for less than 30 minutes, that is mild traumatic brain injury. If the child has moderate TBI, then the duration of loss of consciousness will be from 30 minutes to 24 hours. The severe traumatic brain injury, the child will have loss of consciousness more than 24 hours. Or you can use post-traumatic injury amnesia as indicated here. So, as I said at the beginning, traumatic brain injury is huge. So what are the specific brain injury we're talking about? Or what are the differential of traumatic brain injury? So traumatic brain injury can be the skull fracture, which can be depressed or non-depressed, can be a epidural hematoma, or can be subdural hematoma, can be intraventricular hemorrhage or intracerebral hemorrhage. It can be subarachnoid hemorrhage. It can be penetrating injury. All these are differentials of traumatic brain injury. So you need to know it from the images. If you see this kind of bleeding, you know this is epidural, this is subdural, this is intracerebral, this is intraventricular, this is a subarachnoid, because the management is different. Another type of injury is diffuse axonal injury. The last is how do we investigate for a child presenting with brain injury? Number one investigation is brain CT scan. This brain CT scan will show you the scar, if the scar is intact or not, will show you the brain tissue, will show if there is hemorrhage, they will show it if there is involvement of the ventricles, and they can show if there is herniation. The second investigation is brain MRI. This is the best, but in emergency settings, this is not realistic to be done. As a result, most of the time is a brain CT scan. Another investigation is scar X-ray, but this will show only the bone, will not show the brain tissue. Another investigation that can be done in emergency settings is cranial ultrasound. This is done in young children who still have open fontanelle, so they can show if there is bleeding in the ventricles, if the ventricles are dilated or not. But also, we can do the blood tests. This blood test is not for confirming brain injury, but rather to find any complications. For example, if the child is bleeding, the patient may have hemorrhagic shock, you need to do grouping and cross match, you need to know the hemoglobin. You can do the chest X-ray if the patient has chest injury, you can do the abdominal ultrasound. So other investigations will depend on how the child is presenting. So in the study that was done in Cameroon, looking at what are the CT scan findings in those children, they found that the most common findings was cerebral edema, followed by skull fracture, followed by acute subdural hematoma, followed by intracerebral hematoma and epidural hematoma. So these are the common findings in CT scan done in pediatric patients. This is the end of my presentation. I welcome the second presenter and thank you for listening.
So Brittany, I'm gonna go ahead and share my screen. Let me know when you guys can see my screen. Can you see my screen?
Yes, you're not yet in presenter mode. There we go.
Okay. So so hi everyone. Thank you, Dr. Biita, for that good introduction. I think he covered a lot. And moving forward, my name is Dr. Chidi, and we'll be talking about the management of pediatric traumatic brain injury. So now you've already seen, the overview, the things you need to look at, the way you do initial assessment. We're going to be going through this outline, the initial resuscitation of traumatic brain injury in children, who should get a head CT or head imaging, and we are going to be discussing the PEM criteria. We're going to talk more about that. Then the next, we'll talk about the management based on severity of traumatic brain injury. We'll throw a little bit light on penetrating traumatic brain injury. Then we'll finish with non-accidental head injury, or we call it child abuse. So for ED assessment or the initial stabilization, like everything else, we do a primary survey. Yes, Dr. Biita did point out on things you should look out for when you are doing this primary survey, but I'll focus on things that when you find things that you need to address when you're doing your primary survey. So for airway, for any kid that you see that there's declining consciousness, that has significant altered mental status, GCS of less than 8 or equal to 8, those ones you want to go ahead and intubate them. Then also, feel free to do to open up the airway, chin lift, jaw thrust. There's no contraindication for that. But however, whenever you see any child with signs of basilar skull fracture, be it CSF rhinorrhea, you don't want to do any nasotracheal intubation in a patient like that, because you may be passing your tube into the brain. For breathing, definitely you want to make sure that you prevent hypoxia, because hypoxia is one of the single most important thing that you can do to avoid secondary brain injury. So you want to maintain saturation, the oxygen saturation that is above 90%. Then for the ones that are showing you sign of raised intracranial pressure, you want to hyperventilate them so that they'll maintain a partial pressure of carbon dioxide between 30 to 35, to prevent signs of herniation, to prevent herniation, and also to decrease swelling of the brain. For circulation, you want to prevent hypotension, because hypotension is one of the other things that could cause secondary brain injury. Then whenever you see any hemorrhage anywhere, be it in the scalp, be it in any part of the body, you want to, secure that bleeding and make sure you're not losing a lot of blood. For disability, we've already talked about GCS. Pediatric GCS is a little bit different, especially for children that are not talking yet compared to adults. And when you're assessing disability, you also want to check the pupils, because if it's blown, then that is cueing into something is going on in the brain. Then you need to act fast. Then also when you see things like posturing, lateralizing signs, or for an infant that has a very tense fontanelle, then you want to know that those are clues that you have a significant brain injury going on. Then you want to start acting fast. For exposure, you want to do your full trauma survey. Make sure you're preventing hypothermia. These are things that will worsen secondary injury. Then assess for other things of for signs of non-accidental trauma. Like we've mentioned, one of the causes of traumatic brain injury in children is non-accidental trauma, meaning child abuse or maltreatment, right? So when you're exposing this child, you check for bruising, or when you're taking your history, you pay attention to the kind of history they are giving you, whether you are getting anything that is inconsistent. Let's say they are telling you that a 2-month-old, they left the 2-month-old on the bed. They went to go and get something. Then they saw the 2-month-old crawled and fell on the ground. That history is a little bit inconsistent with that patient's age, because you know that a 2-month-old should not crawl. So when you are getting a history that does not make sense, then you should start worrying about non-accidental trauma. So we have these are 3 pediatric trauma case scenario that I wanted to bring for us to do some sort of mental exercise, and we're going to be talking about this case. While we are discussing about this case with regards to management of traumatic brain injury, I want you to be thinking of what would you do should you see a patient like this in your pediatric emergency department, or even in your emergency department, or wherever you work. Would you get a head CT? What would the assessment be? So towards the end of this lecture, midway this part of the lecture, I will be requesting for most of us to put our response for case 1, case 2, case 3 of what would you do, how would you manage this patient, whether you get a head imaging or not. So for case 1, this is case 1. This is an 8-year-old male that was playing soccer, and he went on head to head with another player. He fell to the ground. He had a 1-minute loss of consciousness. Now he's complaining of severe headache. We did a clinical exam for him. GCS is 13, but he doesn't have any no focal neurologic deficits. So when you see a patient like this, think whether this presentation, the head-to-head collision, 1 minute loss of consciousness, severe headache with GCS of 13 will make you to get a CT head imaging or not. You could put your response in the chat. For case 2, we have a 9-year-old female that fell from a tree, 10 foot tall. She cried immediately she landed on the ground. She ran to the mom, no loss of consciousness. Prior to presenting to the emergency department, she has had multiple episodes of vomiting. She's complaining of headache. By the time you did your physical exam, she has a GCS of 15. She's alert, she's responding to you, no focal neurologic deficit, apart from the only complaint she has right now is headache and the vomiting that she did prior to coming to the emergency room. So would you get a CT for this or not? Put your answer in the chat. Third case, this is a case of 6-month-old male that fell from bed, landed onto a cemented floor. This patient cried immediately, no loss of consciousness. Mom ran, brought him to the emergency room. GCS is 15. When you did the exam, you noted left parietal skull swelling, no step off. The child appears too sleepy to feed. Mom is saying, I'm trying to feed this child, but he's too sleepy, but I'm waking him up. He wakes up, but he's just not eating. No other neurologic deficit. He's moving his arms, leg, pupils are reactive. Rest of his exam looks good. So, like I said, these are the 3 cases. Case 1, would you get a head imaging? Because what we want to discuss is who should be getting a head imaging for a child for a pediatric trauma and who should not. Case 1, the head-to-head collision with brief loss of consciousness, now GCS of 13. Would you get a head imaging? Yes or no? Case 2, fall from height, 10 foot fall from tree, ran, no loss of consciousness, ran to the mom, multiple episodes of vomiting, complaining of headache, GCS of 15, no neurologic deficit. Would you get a CT imaging for this or not? For case 3, 6-month-old male fell from bed onto cemented bed, left parietal hematoma, feeling sleepy, but GCS of 15, no neurologic deficit. So while you think about this, put your answers on the comments, we'll come to it. So who should get CT head imaging for pediatric trauma, for pediatric traumatic brain injuries? So one of the things we pay attention for children that's unlike adults, their brains are still growing. So we are very conscious of who we radiate because, again, there's that risk of cancer that is caused by radiation. The younger you are, the more prone to having radiation-induced malignancy. Definitely there's a rule. I mean, if you have severe trauma that you're having GCS of 13 or below, definitely you should get a head imaging, right? But for the ones GCS 14 to 15, there's a rule, there's a PEM head decision rule that helps us to risk stratify who should really get head imaging, who should not, depending on other factors. So we are going to talk about the PEM head traumatic CT decision rule. So this is a gold standard. This was a study that was done. There was a study that was done in 2009 by Nate Cooperman and some other people, part of the PEM group. The PEM means Pediatric Emergency Care Allied Research Network, and it's based off US here. Together with Canada, the multi-institution, they do a lot of multi-institution studies. So they looked at, greater than 42,000 children that suffered pediatric head trauma, and they were able to put data together and they were able to identify children that are very low risk of clinically important traumatic brain injury. And when we mean the clinically important traumatic brain injury, those brain injury that required surgery, those brain injury that required, significant intervention. So the results of this study, they've been able to validate it across multiple countries with up to 99 to 100% sensitivity, and then does have 100% negative predictive value. But this study, the findings that we use the PECAN pediatric head trauma decision rule does apply only to children with GCS of 14 to 15 with blunt head trauma. It does not apply to penetrating head trauma. So this is the PECAN decision rule that helps us to determine which child with mild traumatic brain injury should get a CT imaging or not. And we do have for two ages. We have for PECAN for age greater than 2-year-old. Then we have the one for age less than or equal to 2-year-old. So for the one for age greater than 2-year-old, first thing we do, we check GCS 15. Do we have GCS less than 15? Do we have any altered mental status? Do we have any sign of basilar skull fracture? If we do have that, this kid falls on a high risk, and the approximate rate of clinically significant traumatic brain injury will be 4.3%, and that means CT head will be recommended. So if you see any child with this presentation, go ahead and get a CT. Then when this is negative, that means if you don't have any of this initial one, which is GCS less than 15, altered mental status, no sign of basilar skull fracture, you go to the next step. Next step means you're checking a history of loss of consciousness. Do you have any history of vomiting, severe headache, severe mechanism? Severe mechanism include motor vehicle accidents with ejection, fall from height greater than 5 foot for greater than 2-year-old, fall from height greater than 3 foot for kids that are less than 2-year-old, and many other things that will qualify as severe mechanism. If you do have any of these, then the risk of you having clinically significant traumatic brain injury is 0.9%. When you have this, you want to have you have two options. You have the option to observe the child for up to 4 to 6 hours in the emergency room or in your setting to see if there's any declining clinical status, or you go ahead and get a CT at that time. Most of the time, this is also the point that you may want to make a shared decision with the parents and see what their preference is. Also, even you as a clinician, if you're depending on other things, other stories that you're hearing, your clinical judgment, maybe you've seen multiple kids that had this similar story and they ended up having clinically significant traumatic brain injury, or something within your gut is telling you something is wrong, then you should go ahead and get the head CT at that point. But if this is negative, that means you don't have any loss of consciousness, no vomiting, no severe headache, no severe mechanism, then that means you fall under very low risk. And very low risk, the risk of clinically significant traumatic brain injury will be less than 0.05. CT head imaging is not indicated in that case. The next will be the age for PECAN criteria decision rule for age less than 2-year-old. Similar thing, this is just a card that they produced that they shared around when they were implementing this after the study. First thing you look at is, do we have any sign of altered mental status, GCS less than 15, or sign of palpable skull fracture? If we do have any of these, this child is high risk, and the rate of clinically significant traumatic brain injury will be 4.4%, and for that case, CT will be recommended. If you don't have any of this thing in the high risk criteria, you go and check for, do we have any loss of consciousness greater than 5 seconds? Do we have any non-frontal hematoma? That means things like parietal hematoma, things like occipital hematoma, or severe mechanism, or even if the child is not acting normal per the parent, if any of this is positive, the risk of clinically significant intracranial injury is 0.9%, and you should decide whether between observation for 4 to 6 hours versus getting CT imaging at that point, which one would you want to do? Then if this is negative, then like you've looked at this thing and this part of the history, and you don't have any of this, then you fall under very low risk, and the risk for clinically significant intracranial traumatic brain injury will be less than 0.02, and for that case, CT head will not be indicated. So pearls with regards to pecan head decision rule. The ones, like we said, the ones that fall intermediate risk, we observe them for 4 to 6 hours before, before we decide whether we need to do CT, because if they stay stable or looking better, not deteriorating for 4 to 6 hours, that will help you to avoid doing unnecessary CT imaging. We've already spoken about the risk of radiation for children that are younger, that is higher. And also you as a clinician, your gestalt is a better specificity than the rule alone. So if you're worried, then you should go ahead and do it, you as a clinician. Then also, pecan rule does not apply very well for infants that are less than 3 months old. Reason is that you want to, have low threshold to get a CT for this age, because their clinical exam, for you to be able to get their exam and also be sure of whether they are sleepy, whether they are lethargic, is very hard to really say. So if you see anything that is making you worried in that age group, you are better off, you should consider you should have a low threshold to get a CT scan. Then also, pecan head decision rule does not apply for penetrating head trauma. It does not apply for children with bleeding disorder, like things like hemophilia. And also, it does not apply for suspected non-accidental trauma, like child abuse case. Those ones, if you think any of this, go ahead and get the CT. Or like if you have any patient with this, go ahead and get the CT. So, Brittany, from the chat, how do we do? What's the response so far?
So
For case one?
as we go through, people have been listening to what you're saying, and we've been getting some different results. For case one, I think initially there was some mixed results because it seems like a pretty low mechanism, but he has a decreased GCS. So initially we had yes, we would get a CT, and no. As the lecture has progressed, more people are saying yes about that one. For case two, we also had some mixed opinions at first, but we've started to see several people saying that they would discuss with family. And for case three, we continue to have some mixed opinions.
Okay. Thank you so much for that. Thank you. So, I mean, yeah, that's the reason why we have this lecture, and also, it's, you will see a lot of us during practice. We'll go and try to remind ourselves what is the pecan, where did this child fall, because sometimes it's hard to carry all this in your head. But yes, this is where all these 3 cases will fall, depending on, from the information that I provided for these cases. Case one, remember we said this is an 8-year-old, so he's, for the pecan rule, he's greater than 2-year-old, and he had a head-to-head soccer collision. So the mechanism is not as severe kind of mechanism, but his exam finding is telling you GCS of 13. So just going off that, GCS less than 14 should be high risk. So this kid should get a head imaging, no delay, should go ahead and get it immediately. For case two, 9-year-old, she fell from a height of 10 foot from a tree. So this is a severe mechanism, right? But has GCS of 15, no loss of consciousness, although multiple vomiting and headache, but no neurologic deficit. So she does not meet the high risk, group, but she kind of, because of her mechanism of injury and the vomiting, she lands herself in the intermediate risk. So this is one of the cases that you either decide to observe for 4 to 6 hours, or you have conversation with the, or you decide to CT, depending on how worried you are or not, Then for case 3, this falls under less than 2-year-old, pathway. And also this is a 6-month-old fell from, from bed to cemented floor and cried immediately, no loss of consciousness, GCS of 15. But the thing that is being pointed out here is he has a non-frontal scalp hematoma. This kid had a left parietal hematoma. And also one thing that is concerning here is the kid is sleepy but arousable, right? So sleepy but arousable does not really, they didn't kind of specify clearly whether it should be something that that falls in the within the PEM algorithm, but the non-frontal hematoma falls in the intermediate risk. If, for me, from my clinical practice, if I see a child around 6 months, my clinical gestalt will push me to want to get a CT earlier than later. Some other people may feel comfortable, oh, maybe this kid, yeah, the mom says sleepy, but by the time I'm talking to this kid, the kid is smiling and laughing and giggling. Maybe that will be a case that you want to observe. So there's a lot of other things that are not within the rule that you want to be considering. Or let's say I'm seeing a mom, that seem not to care about the way the child is crying. She looks very distant from the child. Then I'm worried about, okay, maybe there's another factor here that I need to consider, being that, oh, maybe this is a case of non-accidental trauma, or maybe even if I discharge this patient, they may not be able to follow up, or if something changes, they may not be able to pay attention and bring this child. So maybe I'll decide to get a head CT at that point. So these are things that we consider. So shifting gears to management, we're going to talk about management of based on severity of pediatric traumatic brain injury. We have the mild, moderate, and severe based on the GCS, and that's the GCS for the different groups is what you can see on the screen. For the mild one is basically most of what we spoke about, is where majority of the pediatric traumatic brain injury that come to the ED, they fall under mild group, and you use your PEM criteria to decide who you want to CT. When the CT is negative, then you feel free to discharge them with head injury precautions. Things that you should pay attention, even if they don't have any bleed in the head or anything like that, is you want to counsel them about cognitive rest, physical rest, for 24 to 48 hours or even beyond. And the ones that play sports or even go to school, you want to counsel them about gradual return to activity, because sometimes about 15 to 30% of children may have, with mild traumatic brain injury, may have prolonged symptoms. So sometimes you even want to arrange for follow-up. Then if you're going to send them home, you want to give them clear return instructions, like if they start to have persistent vomiting, worsening headache, the altered mental status or something like that, seizures, bring them back. Especially, you may want to throw more of this instruction for the ones that you didn't end up getting CT imaging. For the moderate one, these are the ones that are in GCS 9 to 12. Definitely, you want to go ahead and get a CT head imaging for these ones. Most of them, you want to admit them for serial neurologic exam, because the GCS sometimes can deteriorate and you may need to do more. Also, you want to consider seizure prophylaxis like Keppra for this patient, like Dr. Biita said. Kids are, especially the ones less than 24 months with severe traumatic brain injury or abusive head trauma, they are at higher risk of seizure. Then definitely you want to have your neurosurgical consultation, especially depending on the findings that you see when you get your CT. If these kids, even during admission or while they're in your ED, on the emergency department, you've already gotten an initial head CT, and while they're with you and they're deteriorating, you may want to consider repeating the CT head imaging. Some of them might have mild small epidural that is beginning to expand, and that might need an immediate intervention. Next is the severe traumatic brain injury. These are the ones with GCS of less than or equal to 8. These ones, because they are so altered, you want to go ahead and get a definitive airway. You want to intubate them. Then make sure you avoid hypoxia, make sure you avoid hypotension, that they're getting enough oxygen. You want to get emergent CT head to make sure whether they have they will need any sort of intervention, and you want to consult neurosurgery immediately. This is also the group that you definitely want to monitor the intracranial pressure, because sometimes they may require some intervention. And one thing to point out, there's different cutoff for the intracranial pressure for infant compared to to adults. So it's not the same number. When you see signs of raised intracranial pressure, what do you want to do? Especially you have a kid with significant bleed or quick change in mental status or with severe head trauma, you want to raise the head of the bed 30 to 45 degrees. Then you want to consider giving them hypertonic saline. We do favor this over mannitol in pediatrics overall. And also you want to consider hyperventilating them to maintain partial pressure of oxygen, of CO2, 30 to 35. That tends to decrease, the amount of blood flow that is going to the brain. And also, definitely, you want to consult neurosurgery that's immediately. If you don't have neurosurgery in your site, you want to stabilize this patient and ship them out as soon as possible. But when they are having this raised intracranial pressure, they can herniate. So these are cases that might need decompression, cranectomy, or CSF drainage to help to save their brain. Speaking about penetrating traumatic brain injury in children, this is it's less common compared to blunt one, but can be more lethal. Things like gunshots, stab wounds, fall on sharp objects are things that we know that can cause this. It's similar management to the adult penetrating traumatic brain injury. No more change. There's no much difference. You do your initial primary survey. Don't let the dramatic nature of the penetrating injury distract you from doing making sure you get your airway, making sure that the breathing is assessed, that you control your hemorrhage and everything else that you need to do. You want to identify your entry and exit wounds, and you want to consider multiple trajectory for this wound. When you see any protruding foreign body, do not attempt to remove it. That's the work of surgeons. Especially as an emergency physician, you also want to do that in a controlled environment and, make sure you have it. So this is usually something that happens in the OR or maybe angiography suite. Then also, do not try to probe any wound. Do not try to debride any tissue in the emergency room. That should be done in the OR. Then you should avoid compressive dressing over scald effects or places that you have leakage of CSF, because that might be the only thing that might be preventing the person from having significant intracranial pressure. What kind of image do you get? For this, you get an emergent CT imaging. It's no question you have to get a CT imaging for this. And also CT angiogram of the head and neck, because you want to check whether vessels are affected and how much are they affected. But you do this after you've stabilized the patient, after you've gone through your AC primary survey. Also, sometimes skull X-ray can supplement, CT imaging for the to localize your radiopaque foreign body. Like, let's say you have gun pellets within the head. For the ones that you don't think is a magnetic foreign body, then you could do MRI to help you to localize what you're dealing with. For management, first thing is aggressive ABCD, but aggressive hemorrhage control. This is a kid that even if they call you and say, we are bringing a patient like this in, even before the patient arrives, you want to activate massive transfusion, because they do bleed a lot and you want to have a lot of blood to be able to transfuse them as much as they are bleeding. You want to call your neurosurgery on time if you have a neurosurgery within your facility to be on board. And also, if you don't have neurosurgery, stabilize them as soon as possible and start arranging for transfer. As soon as possible. Penetrating traumatic brain injury, they are higher risk of seizure compared to the blunt one. So you want to do your seizure prophylaxis regardless. One important thing to mention is that children compared to adults, children will survive penetrating, most of them compared to adults, right? They will survive penetrating traumatic brain injury compared to adults. So don't see any kind of penetrating traumatic brain injury and say, no, I don't think this child will not make it. I'm not going to do anything. Most of the time, a lot of time, children, they tend to survive. They tend to surprise you. So last one we want to throw light on is non-accidental trauma, non-accidental head trauma or abusive head trauma. This is a major cause of traumatic brain injury death in infants, because they don't speak, people don't feel like nobody can fight for them and all that, or nobody will know when something happened to them. This tends to occur more frequent than we know. Red flags that you should think about is things like subdural hematoma, or let's say you are seeing, presence of hematoma on different parts of of the head, one on the left and one on the right. That does not make sense because most of the time when you fall, you hit one part of the head. So that should make you to worry that whether somebody did punch the child or hit the child on the head multiple times. When you see things like retinal hemorrhage, or like again, when you are seeing inconsistent history, getting that from the parents, or signs of prior injury that you're seeing on imaging, let's say you're getting a chest X-ray for your trauma evaluation and you're seeing posterior rib fractures, then you should worry about non-accidental traumatic brain injury. They tend to have a higher rate of seizure, apnea, bilateral fixed pupils, and they have a higher rate of cerebral ischemia compared to the accidental ones. When you see this and when you're worried about this, you have to do a mandatory reporting. I know Tanzania still does have mandatory reporting for child abuse, same as US. And other things you want to do in addition to your regular trauma workup will be skeletal survey to see whether you are seeing any other fractures that are concerning, or even old fractures at different stages that will make you worry. The ophthalmologic exam will help you to identify things like retinal hemorrhage that we see in shaken baby syndrome. And you want to consult your social work, you want to consult your child protective services, to get involved with these patients. Then of note, pecan head rule does not apply for when you are thinking or when you're concerned about patients with abusive traumatic brain injury. So you should have low threshold to obtain CT imaging for patients like this. So we're wrapping it up. And so this is the summary. We've gone through all the things that we do for management, and the key takeaways I want you to leave this lecture with will be for traumatic brain injury, especially the mild ones, you want to use your pecan head decision rule to decide who should get CT imaging and not put every child that comes with mild traumatic brain injury through radiation. So you can reduce unnecessary radiation. Then also, the ones that are present to your emergency room, while you're assessing them, prevent hypoxia, prevent hypotension, like Dr. Biita said. These are the things that if you don't do, they can cause secondary brain injury. Then also know that, children are not small adults. We have different cutoff, even the way we have different cutoff for heart rates. That also applies for intracranial pressure and cerebral perfusion pressure, which could be different cutoff for children. So don't wait for you to see the same high intracranial pressure similar to what you have in adults before you get concerned. For penetrating traumatic brain injury, you want to go ahead and stabilize, get your CT imaging, CT angiogram fast as you get that as fast as possible. Do not remove any foreign body. Get neurosurgery involved early. And for your non-accidental trauma, the ones that you're worried about, suspected child abuse, you want to consider getting your head imaging super fast. And whenever you have a traumatic brain injury, you should also consider that. And lastly, when you're going to discharge this patient, the ones with mild traumatic brain injury, counsel them on possible return instructions, and also that sometimes the recovery could take a while so that they know. I think that will be it. Thank you so much, Asante. And it's time for questions.
Okay, thank you very much, Dr. Biita and Dr. Chidi. A very nice presentation. And I'm quite sure that the participants have learned a lot, and probably this has also triggered more learning on managing traumatic brain injuries in pediatrics. So I know we are past the hour, but then I'll just welcome any question in the next 3 minutes so that we wind up the session at 10 minutes past 4. But there are also questions on the chat. So if Dr. Biita and Dr. Chidi, you could look on the chat, I'll read them through, but then you can also look on the chat.
Sure.
We have a question. The first question says, PECAN recommends observing children with intermediate risk head trauma for 4 to 6 hours before deciding on a CT scan. My concern is that if a patient presents 8 hours after the injury, An additional 4 to 6 hours of the observation could delay the diagnosis of a serious condition such as an epidural hematoma, where early intervention is critical. In this scenario, should we still follow the pick and observation strategy, or should the delayed presentation prompt a lower threshold for obtaining an immediate CT scan? So that's one of the questions from one of the participants.
Okay, so
And
that's okay. You want me to answer, or you want to finish all the
yeah,
questions that I can answer?
no, you can just answer and then I'll read the next question.
Okay, so the good thing about the pecan head decision rule is that the observation time starts from the time of injury. So the 4 to 6 hours is basically from the time of injury. So if the patient presents to you and it's been 8 hours from that time of injury, and you see this patient and the patient looks great, GCS of 15, smiling, not vomiting, looks great, then you shouldn't worry about observing the child for prolonged time. Now, if you see the patient and the patient is giving you symptoms, let's say the patient is still, giving you GCS of 13, or the patient is altered, vomiting back to back, that should make you to worry, and that should make you to consider seeing. I mean, if the GCS is low, then automatically you want to go ahead and get the CT. If the GCS is, somewhere between, GCS is 15 and the patient is falling in an intermediate category, but that time you've completed your hour of your duration of hour of observation. So you should be able to take a decision at what you are seeing at that time. Does it still make you worry? Is the person still persistently vomiting? If that's what I'm seeing, then maybe I'll consider scanning the person. If the person is still giving me, severe headache and all that, or that the patient looks good, GCS is 15, and I'm doing all my exam. Maybe it's concussion, depending on what you're seeing. But I mean, 8-hour mark, I'm seeing neurologic deficit, you're getting a head scan, even if you have a GCS 15.
Okay, thank you very much. And I think that the participant and the rest have gotten a response for that. The next question was, please, can you elaborate more and give reasons on the preference of hypertonic saline over mannitol in pediatrics?
Okay, I mean, there's no big thing other than most of the time there are some studies that they compared both of them, and they've seen better resolution, better response in terms of management of things like ICP compared to mannitol. Then also, even when it comes to ease of use, right? The ease of use, if you try to push mannitol versus to give hypertonic saline, you will know the difference, that sometimes it's hard to give mannitol fast the way you want it versus the hypertonic saline. But this is mostly based off studies. But like in a place where you don't have the hypertonic saline, there's nothing that stops you from giving mannitol.
Okay, thank you very much. I think, again, the participants have gotten the response from the answers that Dr. Chidi has just responded. So I'm just trying to look on the chat to see if there's any other question that I missed. But I think so far those were the two questions that the participants had.
Yeah, I'm
So
looking
as we
through. I'm not
wind
seeing
up,
another question. Okay.
so as we wind up, I'd just like to remind all participants that have joined in. First, I would like to say thank you for joining in our PEM lecture series for this month. And we are sure that you have learned a lot on our today's PEM lecture series. The PEM lecture series is conducted every month, and we'll have our next PEM lecture series the coming month, and we'll share the details of the talk on our social media and on our WhatsApp groups, as we have always shared the information. It is a CPD accredited activity, and as I said earlier, we can now claim the CPDs, which I'll do it for you. So for those that have joined in, make sure that you have written your MCT number. For those that joined in the previous 4 PEM lecture series, I'll also make sure that you all get your 3 CPD points. There have been requests on sharing the PowerPoints. So what we do, as said, we have a YouTube channel where we are going to share the recorded videos of this lecture series so that anybody who wants to go back and learn, who missed any session, you can always access it through our YouTube channel. The link that I sent, it sends you to the YouTube channel where we have different playlists for different materials. So when you go in, just look for PEM lecture series 2025 or 2026 as a playlist, and you'll have all the recorded videos, which you can view, download, and go back to them at any time. But having said so, I would like to say thank you once again, and I would like to wish a good morning to our colleagues in the US and a good evening to our colleagues in Tanzania. Thank you very much. Wishing you a good evening.